キャロル・ハーベイ先生はメルボルン大学精神医学部准教授、社会心理リサーチセンターのディレクターでいらっしゃいます。またメルボルン保健局の顧問精神科医もされておられます。でオックスフォードですとかロンドン大学で、生理学医学を勉強されまして、1994年からオーストラリアに移られて、さまざまな重責を負っておられますが、現在1997年から2005年にメルボルン大学の精神学の上級講師になっておられて、2006年に今の職に就任されておられます。で先生は特に患者と家族を巻き込んだ効果ある介入手法について、力を入れておられると、いうことですけれども、その他臨床のお仕事ですとかさまざまなサービスの開発、それから心理社会的なアプローチに関して幅広く研究を行っておられます。また国の調査にも関与されているということでございます。ご紹介を終わります。よろしくお願いします。どうぞ。
Thank you, Dr. Noda, for that introduction. And thank you for inviting me. Good morning, everyone. I hope to address a little the last issue that was raised about involving patients and families in providing the extra resource and capability that could be useful for developing our services, because I believe my topic of psychosocial treatments offers some of that potential for us. So I'm going to first of all talk a little bit about recovery from mental illness, and really acknowledge that we're in a situation where across the world more and more people with major mental illnesses are living in the community rather than spending long periods in hospital. And I would suggest, and I hope you agree, this is humane and it's consistent with the hopes and the aspirations of people with mental illness and their families. Now, most patients want to live as regular citizens. They want to do the things that we all do, such as studying, working, and that's whether or not they are free of the symptoms of their illness. So, things like having friends, having a job, experiencing a better quality of life, feeling empowered, have become important goals for personal recovery. Now, these aspirations of patients and their families are supported by the development of high-quality, comprehensive community mental health services. And of course, modern medicines play an important role in reducing symptoms. But I would suggest to you that people with mental illness need more than this, need more than good medicines. And this is why I suggest this to you. This is data from the recent Australian survey of psychosis carried out in 2010. Now, this was a survey of almost 2,000 Australians with psychotic illnesses such as schizophrenia. As you can see, most were living in the community and were not in hospital. So 98% were living in the community. Now, a very important question we asked these people was to identify the top challenges that they would face in the next 12 months. And I've provided you the top 5 here. Now, we're a well-developed country, Australia, but top of the list was lack of money. The second challenge was social isolation. The third was the lack of a job. The fourth was poor physical health. And the fifth concerned uncontrolled symptoms of mental illness. Now, I would suggest that if such a survey was conducted in Japan, you would find similar answers from your patients and families. So part of the solution for these challenges, I believe, apart from good medicines, are psychosocial treatments. These are necessary as well. The reason being, they are more focused towards overcoming these challenges that were identified and helping patients achieve their personal goals. In other words, to assist people with mental illness to play a full role in society. Now, a number of the psychosocial treatments have been shown to be effective by very strong scientific research, and they're now recommended in guidelines for mental health practice. And I want to illustrate this to you. So here are those 5 challenges that we identified in the recent Australian survey. Now, there is a psychosocial treatment to help patients find and keep a job. And of course, this is going to address the challenge of being unemployed. There is also a psychosocial treatment to help patients to improve their social skills. And it's understandable that that could improve their social contacts and decrease their isolation. We have a psychosocial treatment to help the family and the patient together reduce their stress. And one of the important outcomes of that treatment is to increase the employment prospects of the patient and the social contacts of the patient and the family members. And it also works to help the patient and family together to manage the symptoms and reduce relapses. So it has a number of beneficial effects in terms of those challenges. There's also well-recognised treatments that help the patient to recognise and cope with the relapse. And of course, this is going to help them keep their symptoms under control and the number of times that they need to go to hospital. And finally, we have therapies to help the patient understand their symptoms differently, so-called CBT. And of course, this also helps with keeping symptoms under control. And as you would expect, if a patient gets a job through a psychosocial treatment, they're likely to have more money, and this assists with their number 1 challenge. And there's pretty good evidence that being employed and keeping your symptoms under control will also assist you with better physical health. So I suggest that if we include psychosocial treatments in what community mental health services deliver, we are better able to help patients to address their key challenges in life. The second part of my talk, I want to illustrate this a little more for you by talking about family psychoeducation for people with psychotic disorders and their families. So I hope that this will provide an example of the value of psychosocial treatments for us all working better together to deal with mental illness in society. First of all, I want to just touch upon the strong need that families have for involvement in good community mental health care. Most families do want to be involved in the treatment and care of their relative with mental illness and to provide assistance for their recovery. we now have effective ways of involving families that have been developed over a number of years, and they're scientifically proven. These result in patients experiencing many improvements themselves. And altogether, these programs are known as family psychoeducation. There are a number of examples of these, but they're all known by this term. And I'll tell you a little bit more in a minute about what this looks like. But first of all, we need to acknowledge that the impacts of mental illness, not just experienced by patients, but are also experienced by family members. So things like confusion, grief, guilt, blame, these are shared by the patient and the family. In our own Australian research, we found that more than 40% of carers of people with severe mental illness were assessed as likely to have diagnosable depression or anxiety. So they themselves experience an impact of their caring role and their concern for their ill family member through experience of depression or anxiety. This same group of carers that we interviewed were nearly 10 times more likely to be socially isolated than other people. So another impact of being a close family member is that you may be less connected with others, more isolated from the rest of the community. So how might family psychoeducation work and address some of these issues that I've spoken about? Well, we know that stress can lead people with mental illnesses to more frequent relapses of their illness. What family psychoeducation does is it helps to decrease relapses by reducing stress within the family. The family stress is reduced through providing education and teaching new skills to all the family members. So what happens is that families take part in 12 or more family psychoeducation sessions over 6 months to 2 years to participate in the full program. What does it look like session to session? What are the families involved in? Well, the first important point is that the patient and family are involved together in the sessions. This is very important because it leads to greater understanding of all family members about the mental illness and its impacts, and it helps to empower the patient to involve the patient in sessions with the family. During the sessions, information about the illness is shared and it's discussed in some detail between the patient and the family members, with the trained staff supporting and facilitating that discussion. The family learn to recognise and cope better with the relapse. This can happen for families. We've worked with families who have maybe had the experience of mental illness for 15 years or more. But surprisingly, there's still a lot of learning from these sessions, because the family psychoeducation provides a safe and supported environment to discuss some quite challenging issues like symptoms and difficult behaviours. Training is also provided in the sessions to improve how the family talk together and to help them solve problems more effectively. And part of the sessions includes setting goals to help all family members achieve their personal goals. And this is one of the ways that people can start to connect back with their role in society through the goal setting. Well, what's the scientific evidence for this approach? Well, it's strong and it's been around for a long time. So 40 years with more than 50 strong scientific studies, what we commonly refer to as RCTs, the gold standard trial, show that this approach works for people with schizophrenia, and it also works for people with bipolar disorder and major depression. A key finding is that for families who participate in this approach, the person with mental illness experiences half the usual number of relapses and admissions to hospital, which is an important impact in itself. Oops. Okay. So just to say a little more on how this approach helps with leading an ordinary life in society, which is the aspiration of most patients. So for the patient, they're more able to interact in the usual way in society, socially, and they're more likely to get employment. For the family, they feel less burdened by their caring role, they have better relationships with the patient, and they're more able to get on with their own lives as well. So this seems like very good news, but there's a slight problem. Despite the strong scientific evidence, this approach of family psychoeducation is still not widely available around the world. So this includes in Australia. Certainly, to do this work, mental health professionals need special training. And most of our mental health professionals are not trained in this way of working. But even when staff are trained, what we find in the research is that they only involve a few families, maybe 3 or 4 at a time, in their work, unless other changes happen to support them to do this work. So training isn't enough on its own. We have some research programs in Australia now that I'm going to mention briefly, where we've learnt about many of the other changes needed to help staff to work in this way. And I'm going to mention just 2 of those things that we've learned. The first concerns what families need from community mental health services. So what we find in Australia, and I'm sure it's true in many other countries, our services need to be more family friendly. So we need services that open outside of office hours, and we need services that will meet with patients and families in their homes if that's what they want. We've identified that all families need early contact from the service that's treating their loved one. We shouldn't leave it to the discharge time from hospital. The contact needs to happen as soon as the patient enters the hospital or enters the community service. Now, not all families need or want this intensive approach of family psychoeducation, but all families need something, and that is information and some discussion about the kinds of things that could help them. So all families need that basic requirement. So these are some of the things we've learned that are often lacking in services to make them family friendly. The second thing we've learned is that we need to improve the way we offer our mental health services so that they can involve families more. One thing we need to do is give a higher priority to psychosocial treatments like this one. We need to make sure that staff are not so busy that they have no time to spend involving families. And the other thing we learned was that it is very helpful to have someone in a community mental health team or an inpatient team that will be the champion for this kind of work. So the person that says, this is the work that I believe in, I'm passionate about it, I will help everyone else to do it by supervising and mentoring other staff and working with them. So in conclusion, I suggest that psychosocial treatments are important because they can help patients live as regular citizens in society. Certainly, staff need training in these treatments, but so that these treatments become more widely available to all of those people that need them, we also need to improve some things about our services. So we need to consider the types and variety of mental health services we offer to patients and families, and the way that we offer those services to patients and families. Many thanks for your attention.
ハーベイ先生、ありがとうございました。精神障害者の心を支える環境というものの重要性、特に、ご家族等のですね、支えについて、サイコソーシャルトリートメントというものも、お示しされながらですね、非常に地域精神保健サービスという点から重要なご講演をいただきました。フロアの方から、ご質問。はい、伊藤先生。
伊藤純一郎と申します。ファミリーサイコエデュケーションについてなんですけども、私たちもグループセッティングで、ファミリーサイコエデュケーションプログラムをやっていいアウトカムを出しています。でとても大切なプログラムで日本の中でも普及させようとこの10年ぐらい努力しているんですけれども、やはりなかなかスタッフを育てるのがスタッフの数が足りず、これは日本の場合家族への支援にファンディングがなかなか下りないっていうことがあるんです。でオーストラリアの場合そういう家族支援に対するファンディングっていうのを州からきちんと取ってらっしゃるんでしょうかっていうことが一つと、あともう一つはその延長で僕たちは今ファミリーとファミリープログラム、そのファミリーメンバーがファミリーメンバーを教えるというようなプログラムも展開しているんですが、それも大変パワフルでいいかなと思ってるんですけれども、先生のお考えを教えてください。
Thank you very much. I think in response to your first question, we have similar challenges in Japan and Australia. We don't have sufficient policy support and funding support for these kinds of work. And as I indicated, we also need the services to change quite significantly for these things to happen more commonly, not just to have trained staff. And that's what I've been interested in my research role, understanding the other things we need to change so that we're not waiting 10 years for more of these programs to be available. So I think we need more and more research effort in this direction. We don't have any different funding situation in Australia to yourself. As you indicated, you can see families in groups. That is also a scientifically proven method, and it's great that you're doing that. The family-to-family approaches, I also endorse. Those have some good evidence, and we need a variety of family services, as I touched upon, because different families need different things, but nearly all families need something. And the family-to-family approaches have that potential that you have already spoken about in patients and families becoming skilled and equipped to work with other patients and families.
はい、ありがとうございます。非常に共通のですね、さまざまな一緒に考えていくべきことがたくさんあるということが非常によくわかりました。他にございますでしょうか。はい、どうぞ。
はい、大変に私は家族会の川崎と申します。家族にとりまして本当に有効なお話を伺えて嬉しく思っておりますが、先ほど伊藤先生の方からもお話がありましたように、実は今まで、日本の制度の中では家族支援ということがどこにもありませんでした。しかし今回少し、その家族支援という言葉が制度の中でも見え隠れしておりまして、何としてでもこの家族支援を実現するためにですね、そういう、お金ですね、やはり家族支援をする、コメディカルの要請などに対する、お金をどのように取ったらいいか、もう本当に、苦慮しているところでありまして、国である程度そのような方針が出たということで、私たち家族会としてはこれを強力に進めていきたいと思うんですが、いつでも国から言われることは財源がないということで、もう本当にくじかれた思いでいるんですけれども、なんかそのあたり励ましをいただければと思います。よろしくお願いいたします。
I would encourage you, and I would encourage you to refer to the cost effectiveness evidence, that these kinds of approaches also save money and are cost effective for the government. So maybe that is also part of the message that you can take forward. There are a number of studies that show that, and there is a study by one of my colleagues in the University of Melbourne showing that these approaches are cost effective in Australia, and I'm sure that would apply in Japan. The policy needs to be improved, as you suggest, and I think the only way to really make dramatic changes goes back to Dr. Ito's comments, that the more that patients and families become peer workers in our system, the more quickly things will change.
ありがとうございます。それで先生ありがとうございました。